Hi, everybody, and welcome to the EMS Today Show. And I'm your host, AJ Heitman, editor emeritus, and really pleased today to have Matt Zavadsky with me. And Matt, to many of you, is one of the faces of MedStar Mobile Healthcare. He's the Chief Strategic Integration Officer and Chief Cook and Bottle Washer. And he's also the president of NAEMT and a very busy guy. So welcome, Matt. How you doing?
Terrific, Jay. I'm glad that you're recovering well and you look terrific as always.
Yeah, for those who don't know, I had my left knee replaced, and I have every other place along the suture line is a channel for Sirius radio I've had installed. And then I also have my garage door opener affixed to it, and my wife has installed GPS that will track me if I go to Home Depot or Lowe's. So it has good and bad features to it, but overall it's pretty good. It's been a tough road. How you been?
Terrific. Things are getting a little bit hot in Texas right now with relate to the COVID virus, but everybody's hanging in there pretty well.
Yeah, California as well, and I'm just a firm believer that we're not going to gain control of this until we have some kind of a antidote or dosage. I'm old enough to remember as a kid going into a gymnasium and they gave me a sugar cube to swallow to fix me for whatever it is. That's probably the cause for my mental status these days. But
well, there may be many causes for your mental status.
There is. We just had a nursing home here in San Diego County that had 100 COVID patients, including 30 of which were the staff, and that's pretty significant. And I know that MedStar had, you've got task forces that are really kind of attacking that. You want to talk a little bit about that?
Yeah, sure. So we all know that the population most vulnerable for the coronavirus are the elderly and those with underlying medical conditions. So by definition, many of the skilled nursing facility residents are high risk, and it's oftentimes difficult to isolate those folks, and they do congregate dining typically. So a lot of the facilities become hotspots for the coronavirus. And thankfully, what the federal government, what the state governments primarily have done is they've figured out ways to track transports from some skilled nursing facilities. We provide data to our local public health department on the number of transports that we have for COVID suspected patients from skilled nursing facilities, and then they have other metrics that they use. But when the states identify a hotspot skilled nursing facility, there's a task force here across the state. They're called Emergency Medical Task Forces, EMTF. And the state has worked with the EMTS and the Department of Emergency Management, and teams of fire department paramedics, ambulance paramedics, EMS systems in general will be notified through a very complex communication system that we have set up by an app on your phone that says, okay, EMTF2, we've got a hotspot facility in Fort Worth, Frisco, Dallas, wherever it is. Here's the facility. We're sending you the labels. The COVID test kits are being shipped right now to the local airport. Literally, we pick up the kits at the airport. We go to the facility. Everybody in the facility gets tested. All of the staff, all of the residents. At the same time, we do PPE training and infection control training for the staff, including a train the trainer for N95 fit testing. So the goal is test everybody in the facility, see what the baseline is, how bad is the potential coronavirus going on there, provide all that information back to the state so that the state needs to take additional action, they can. But at the same time, once we leave that facility, and this is all, by the way, done typically in one day, the facility is much better prepared to manage the COVID patients they already have, but also for any other illness that may come down the road. They've gotten good training on PPE and how to don it and doff it appropriately, how to use N95 masks, how to fit test people. So it's been an interesting process. And as of right now, typically just in our region, which is about a 19-county region here in North Texas, we're doing 3 or 4 of those facilities a week. So it's happening pretty quickly.
Well, I'm hoping, Matt, that this cracks the nut on something that always bothered me as an EMS director, an EMS administrator, an operations director, and that is that the nursing homes had a wall between them and EMS. In fact, even an individual crew would go in and couldn't even get basic information about whether the person had a previous UTI or whether it was sepsis or whatever. And so Although now that we have something that basically forces them to work with us, hopefully for the PPE test training and giving them, because they really didn't have the right PPE. By giving them all of that stuff, they'll see that we are a friend, not a foe.
You know, what the feedback has been, AJ, is that there are some facilities that are very receptive, some facilities not so much. A lot of it depends on the ownership. A lot of it depends on the corporate structure that they have. But by and large, they've been welcoming of that information. One of the things that happens with this task force is that there is a state regulatory agency official with the EMTF that goes in. So there have been cases where when the EMTF arrives at that facility, even though the facility's been notified a day ahead of time that this group is coming, they don't let them in. They literally say, no, we're fine, you're not allowed in. Well, the state regulatory authority says, no, they're allowed in, I'm coming in with them. If you won't agree to let them do this and to help you, then we'll close the facility and we'll find other places for all these patients to go. That's only happened once or twice, but it is a great partnership, not only between EMS and the skilled nursing agency or facility, but quite frankly, between the EMS agency and the state regulatory authority, which in our state is Medicaid, and in most cases it's Medicaid or division of Medicaid. And that partnership has demonstrated to Medicaid that EMS is more than just a transport mechanism.
And have you seen, maybe it's a loaded question, have you seen a dip in the deaths from nursing homes since you started these task force visits?
We have, but only in the facilities that we have visited.
Right. Right.
Which is why I think it's ramping up even more with the rise in the overall rate of coronavirus in Texas, California, Florida. You're going to see that sort of best practice happen a lot because everyone is a laser focus on healthcare system capacity, and having residents in a skilled nursing facility being appropriately managed is much better than having those residents have to go to a hospital where you're already dealing with capacity issues.
Now, your governor hasn't done something brilliant like Cuomo did and absolved all of the nursing homes of any responsibility for inadequate testing or anything.
Nope, has not.
I mean, I think that's just egregious. That's, you know, there were people, national celebrities who had people in New York that lost their mother and their father and they can't do anything about it.
Well, and you know, I won't get into the politics of this, but there is a significant philosophical difference between states like New York and potentially California and Texas.
And Florida. And Florida.
Yeah, and Florida.
So let's talk about some of the numbers. I know from my contacts on a daily basis with people all over the country that call volume is down, cardiac arrests are up, funding is down, transports are down. Your experience?
So it's a roller coaster. I'll give you the MedStar Fort Worth perspective and then sort of national. So we all, early on in this crisis, saw things happening in New York, New Jersey, Detroit, Chicago, LA, and we were all freaked out. We said, oh my gosh, we got to stop people from going to the hospital. We got to stop people from calling 911 because, you know, we don't want to overwhelm the healthcare system. So we put protocols into place at MedStar where if someone is suspected COVID and we respond and they're hemodynamically stable, we don't take them to the hospital, even if they want to go. Medical directive said, hey, you know, we leave information. We've created a nice little leaflet for them. We can document what vital signs we had so we can leave it with them. It's got all the information about who to contact, their doctor or other people to get tested, to not bring those folks to the hospital. The tsunami never came. And with stay-at-home orders, people generally, you might be an exception to that, AJ, but generally people, when they're home, they're not doing things that typically generate a 911 call. And because of all of the media coverage and the things that people were hearing, people were afraid to have EMS workers come into their home. People were afraid to go to the hospital for sure. Then you couple that with hospitals that very appropriately limited visitors that might come with a patient to the hospital or if they're in an inpatient status. So what EMS agencies across the country, most of them, the majority of them saw, was this dramatic reduction in 911 response volume. But then in addition, even when they went to those scenes, people weren't wanting to go to the hospital. So we had a number of cases where people were calling 911 to get checked out to see if they're going to die. And if they weren't going to die, they don't want to go to the hospital. So during the peak of the coronavirus shutdown, during the month of May, our response volume was down about 19%. Our transport volume was down almost 30%. And that was being replicated in many communities across the country except the hotspots. Well, ambulance services and EMS generally are a fee-for-service funded system, and that fee-for-service comes from the transport. So if you are not transporting, then you are not generating revenue. Then you take into account PPE and some of the additional expenses these agencies are experiencing. So we did a partnership with the Wall Street Journal. So the Wall Street Journal spent a lot of time going over some of our records and that kind of thing. An N95 mask that we could purchase in January for 67 cents in May was $3.95. Oh, and by the way, the burn rate for how many N95 masks that we were using in our system went from 6 or 8 a day to 250 to 300 a day. So you've got this dramatic reduction in revenue, dramatic increase in expenses, and especially with some of the payroll expenses. You know, somebody has potential exposure, they're on admin leave for at least 3 or 4 days until we can get some testing, and then maybe 2 weeks. You got to backfill them. So it put a lot of EMS agencies in a very difficult, and even today continues, a very difficult financial situation. So now, put all that to one side for a second. We'll revisit that in a minute. So the patients that weren't going to the hospital or who weren't calling 911 got worse at home because they weren't getting definitive care. They weren't going to the hospital. They weren't seeing their doctor. So our cardiac arrest call volume during the month of May was 54% higher than it was May of last year. In July, so far, it's 107% higher. And that also is being replicated across the country. There was just a study that was published out of New York that really quantified that and said, holy crap, our cardiac arrest volume is through the roof. Is it because people aren't going to the hospital seeking medical care when they're supposed to, and they're literally dying at home? They're scared to death. I'm not going to go to the hospital. One of our crews a couple of days ago told me that they had a patient clearly having a STEMI. History, 12 lead, everything indicated a STEMI. And he was adamantly refusing transport to the hospital. And when the crew tried to get him to go, tried to convince him, he said, listen, I know that I'm probably going to die, but I would rather die at home with my family than go to a hospital where they're not going to allow my family to come visit me and die alone.
See, I get that, but the thing that bothers me, and you know that in an urban center like the Fort Worth area and whatever it would be, Dallas or Houston or whatever, a lot of these ethnic groups live in clusters, and there's 14 people in the house. So that one infected person is probably, and I've heard from paramedics that they've had double codes, and pretty soon the mom and dad both die, and then the son dies, and it's a problem. It's a major problem.
So one of the, it's interesting that you mentioned that, AJ. One of the value adds that we've been doing here in our community, we affectionately refer to it, and everybody does now here, as the COVID cab. So Lyft, Uber, all those organizations were not willing to transport people who were certainly COVID positive or even suspected COVID. So we assign people to an SUV, and literally when patients are discharged from the hospital, we take them home because no one else is going to take them home. And a lot of these people don't have transportation. So you don't want them just hanging out in the ER. So we actually had one of our COVID cab EMTs brought somebody home, and she told me the story. I couldn't believe it. Patient was confirmed positive COVID, was wearing an N95 mask, all that kind of stuff, but was stable. So they were taking her home. And when they were walked into the house, to your point, there were 11 people living in that house. Nobody was wearing masks. Nobody was doing anything. And she said, I know that this is going to become the next hotspot because of the thing that you mentioned, the culture of everybody lives together, and it's impossible to isolate in those kind of environments.
So there's some stuff moving that an AMT's been actively involved, as well as IFC, et cetera, and that's to try and get us better reimbursement for treat in place. Can you talk about that?
Sure. So you may know that CMS, Medicare, we use Medicare for short because it's easier to say. Medicare has issued a bunch of waivers, and they have the ability to issue waivers to help improve conditions, especially during a declared public health emergency, which is what we are in right now. So we worked early on with the International Association of Fire Chiefs, the AAA, in some cases the IAFF and others, to try and convince Medicare to pay for initially alternate destinations, which they did. You may know that in April, Medicare issued a waiver that said to ambulance services, hey, on a 911 call, anywhere that you take that patient is going to be a covered destination. So whether it's urgent care, whether it's a doctor's office, whether it's wherever, and then they said, or other locations. So we sort of tease people and say, you could take AJ on his 911 call to a massage parlor as the destination to get a massage to take out the kinks in his knee, and that's a covered destination, and literally it is. But they didn't go to the next level, which was treatment in place. And we've heard from EMS agencies all over the country that the majority of alternate dispositions that they are doing in their community is treatment in place with a referral to their own doctor or to some other location, because a lot of these patients don't certainly need to be transported perhaps anywhere. Now, when we talked with Medicare about that and said, hey, thanks for the waiver for the alternate destinations, but what about treatment in place? And Medicare replied to us literally in writing and said, we don't have statutory authority to pay for treatment in place because the Medicare benefit is a transportation benefit. It's ambulance transportation. So we can change the covered destination and still be within our statutory authority. To pay for non-transport is beyond our statutory authority. That shifted our efforts, all of those large associations, to a legislative answer. So thankfully, we had recently 36 legislators in the House that co-signed a letter to CMS that said, hey, you need to pay for treatment in place because that's the most appropriate care in many cases. It does all sorts of things. So that kind of gave CMS the legislative intent that treatment in place should be a Medicare covered benefit. Now, Medicare said the same thing. Hey, we understand it. We would like to do it, but we can't. Now, we went back to those same legislators and said, okay, the letter was great. Thank you. We need legislation. Would you be willing to sponsor legislation into one of the next COVID relief bills that inserts literally a paragraph that says, CMS, you are now authorized to cover ambulance EMS treat in place as a covered benefit under the Medicare statute, which is the Social Security Act of 1965. AJ, you weren't born yet, but that was when all that was put into place. So we're hopeful, and hope isn't always a great strategy, but we've got some pretty good alignment. As you know, the Senate is putting together a coronavirus relief package as well. So we're now working with some of the senators to see if they will similarly draft legislation, sponsor legislation that goes into the Senate bill as well. What I can share with you, AJ, and exciting, and we often say that a pandemic or a national crisis sometimes melts walls and brings people together. We had a monumental moment last week when the House Ways and Means Committee senior staffers for health wanted to have a conversation about the legislation, about the language, to get some questions answered. Well, the International Association of Fire Chiefs, the American Ambulance Association, and the National Association of EMTs had our leadership and our lobbyists all on the same call with the House Ways and Means Committee because we all had the same message, and it was a show of alignment that often we've been criticized for not having. And it also, quite frankly, helped make sure that the message was very clear from all of these major associations to the Congress that, yes, this is important to all of us and we're all in alignment, so you can't pit one against the other. So seeing things like that, the letter that we all just signed to the White House, another example of not only those three that we mentioned, but the International Association of Firefighters, the NVFC, a number of other associations that all penned a single letter with a single group of signatures, all expressing concern about personal protective equipment and moving up the priority of EMS workers. Right now, EMS workers, AJ, are third in line for PPE. Well, if we're third in line for PPE, you can bet that we're going to be third in line for testing. We're going to be third in line for a vaccine when it comes out. And we don't think that that's appropriate. We think that we should be number one, same as hospitals, same as skilled nursing facilities. So that letter to the White House and to the administration clearly articulates that with literally 5 or 6 different associations all signing the same letter. So there are some bright spots in this pandemic.
Now, with many of these things, they go away when COVID goes away. So what's being proposed as far as treatment in place is something that we hope will continue ad infinitum.
Yeah, specifically with regard to treatment in place, we, in that language, we wrote and proposed that this be a permanent change, not a public health emergency change. And when we had the conversation with the House Ways and Means staff, they opened the Zoom conference call. They opened up the conference call by saying, hey, we have a couple questions we'd like to ask because we're considering this a permanent change to Medicare policy that will impact 60 million Americans. So we want to make sure that we get it right. So the good news is that, yes, we're using the coronavirus pandemic as a vehicle to make what pretty much everybody understands is a logical change to payment policy that pays EMS providers for the care they deliver, not the transportation they provide.
So let's talk about the future. I heard something the other day on a call I was on that, just an example, our pediatric center here, a beautiful pediatric center, before COVID averaged about 5 telehealth visits a month, and they're now up to 3,000 a week. So what does that tell you about mom in the future calling the ambulance when Johnny has the croup or a fever?
Yeah, it is likely that the decrease in call volume that EMS agencies across the country are experiencing will continue because people who thought they needed to call 911 or they would die are realizing that there are other options. Telemedicine is the classic option. So as telemedicine is more available, then they're going to use that. And it's a way to get in front of a provider to talk about your illness, your anxiety, your rash, your whatever, and get a prescription called in, then delivered by Uber Health or whomever. And then also, AJ, every system has the high utilizers, right? The frequent flyers. Many of those frequent flyers were also afraid to go to the hospital. And what they learned is that if they don't go to the hospital, they actually don't die. So we broke some of the pattern of people calling 911 because they were afraid to go to the hospital, but they woke up the next morning and they weren't dead.
Mm-hmm.
So all of those things, and the hospitals are experiencing the same things. When you have hospitals in financial trouble and insurance companies making record profits, that tells you something. United Healthcare, who's MedStar's insurer, and folks that we work with pretty regularly, they reported record profits last quarter. And when the CEO was interviewed, he said, nobody went to the doctor. Nobody went to the hospital. So we didn't pay out any claims.
No any claims.
Right. So it's like Geico or the other car insurers who have said, we're going to reduce rates 10%, 20%, because people aren't driving as much as they were in the past. Our claims experience is down, so we can afford to lower premiums. Now, whether or not that happens with health insurance remains to be seen. But what you ask is a very astute question, is the change in prevalence of telemedicine is primarily because of the change in the payment policy for telemedicine. So one of the waivers that CMS issued early on in the pandemic was they relaxed the requirements to be eligible for reimbursement for telemedicine. One of the big ones was the origin. So the origin, typically for a telemedicine visit to be eligible for reimbursement, has to be another healthcare facility. Well, they waived that. And they said, no, it can be from someone's residence. So suddenly now, a resident's telemedicine visit is a covered origin. They also eliminated some of the HIPAA requirements. They've eliminated the video requirements to be eligible for reimbursement. So suddenly, by realigning payment policy, you made more resources available for people to use things like telemedicine. And what may happen, AJ, is that when CMS does the analysis and says, you know, we went from paying $1.50 a month for telemedicine to paying $1 million a month, but we reduced our spend for ER visits by $100 million, they might not go back. They might keep that waiver going as long as they can and maybe just make it new payment policy. So for the EMS providers, that's both a blessing and a curse. It's a curse because it's going to impact our call volume. It's a blessing because the treatment in place and the alternate destination, the things that were part of the ET3 model, and we should talk about that at some point during this conversation as well, is also going to yield better outcomes and a tremendously reduced expense for Medicare. So we were on a conference call with Seema Verma a month ago or so, and during the call, somebody asked about the duration of these waivers and that most of them were put into place during the public health emergency. And her comment was, it's going to be harder for us to undo some of these waivers than it was to put them in place. It's going to be harder, her words, to put the genie back in the bottle than it was to let the genie out, and we might not want to.
Well, I think the numbers and the money, they'll follow the money. And so where do we go in EMS now to fill those voids, the transports that we're losing, the elective surgeries that are canceled? And now that volume will pick up, but some of the other things will not. And so where do the astute EMS managers find the money?
So you have to find the money by doing things that you'd always thought about, but people weren't receptive to pay for. So we talked before we got on the official recording about things like contact tracing. So there is a true need for contact tracers, and there's going to be for quite some time.
Yes.
EMS is the logical contact tracing entity in every local community. They're trusted. People are going to talk to them on the phone when they call. If they do have to go out and actually see somebody, they're going to be in uniform. They're knocking on the door is going to open. That is a void that has been created because of the coronavirus that EMS is a logical fit to. Here at MedStar, we've been doing actual COVID testing. So every morning here at our headquarters facility, we have a line of 20 to 30 cars of people who've been referred by the health department to go to MedStar, get your coronavirus test because they're being monitored for development of the disease, alleviation of the disease, whatever it is. That's one opportunity. Another opportunity is we go out to the homes using our community paramedics. And we started that like day 2 of the coronavirus. The health department said, hey, you've got all these community paramedics.
And who pays you for this though, Matt? Are you being paid for this?
We are. We're being
By
paid.
who? By the health department?
Yep, being paid by the health department through what we call in Texas the STAR request, but it's through public funding that's been released through the CARES Act to do these types of things. However, and you raise a great point, AJ, this is an opportunity for us to prove that by doing these interventions, we improve the health of the community, we improve the experience of the patient through navigation, through doing things that keep them out of the hospital, and demonstrate value by reducing the expense to the payers. We've got payers here in Fort Worth, and they have the same in Northern California and New York and all over the country that have said, you know, we've wanted to look at a different payment model for EMS for a long time. This crisis, this pandemic gives us the opportunity to do it under waivers, and they're willing to pay for it. So the revenue that can be derived by proving that value can make up for some of the non-transport revenue. I truly believe that the things that were contemplated under ET3 are being implemented already, and we're going to show to
Hmm.
the payers, the ones that sign the checks that keep our people employed and keep us in business, that we bring much better value keeping people out of the hospital than taking them to the hospital. And that's our opportunity right now.
Now, have you in MedStar, have you had to lay off any staff?
We have not. We've been very fortunate. Even when our call volume decreased, now, MedStar is a little bit unique. We do dynamic resource management. Some
Hmm.
might refer to it as system status management, but we can flex staff. So our core schedule is a 12-hour shift, and they rotate four 12-hour shifts one week, three 12-hour shifts the next week. We were able to adjust staffing to match the new call volume. We reduced some hours of people, but we kept them employed. They kept getting health insurance because we were able to change our staffing model. Not a lot of EMS systems can do that. If you're in an EMS system that has a fixed schedule, so they work 24/48s, or I guess now they work 48/96s, or 96/180s, whatever it is, you can't flex staff. So the pressure on those organizations are going to be much harder. Um, I was talking with Gary Ludwig a couple of weeks ago, who's president of the National Association of Fire Chiefs, and they surveyed their members, and almost 35% of their members who responded to the survey said that they're being asked by their cities, by their counties, to do 5, 10, 15% budget reductions going into the new fiscal year. And when you're looking at that much of a reduction, that has to come from staff. So it's going to be very difficult for really every type of provider, whether you're public utility, private, for-profit, city service, fire department based. Everybody is going to have a very difficult 2020, 2021 fiscal year, and probably beyond.
Well, I have two messages. One is that there aren't many services that have really had a hand in glove relationship with their health department, and they should,
Right.
because the health departments right now have more money than they probably can spend. And then the second is anybody who's listening who's not familiar with contact tracing needs to read up on it, because there's nobody better that could be a detective and be a contact tracer than an EMT or a medic. And the rate that's being paid to these contact tracers is in some places $22 an hour. That's more than they're making as an EMT transport. And so, we have to think about this as, an ambulance service could even hire a couple of people to do contact tracing under the name of their service, see how those people work out, and then move them into the EMT program, because they're so good on the phone and they're so good asking those questions.
Customer service.
It's saving lives. It's particularly,
Yeah.
and this is really particularly in rural areas, because if you're down in Florida, like somebody said, Katie bar the door, the horse is already out in Florida. I mean, contact tracing for thousands of people around the beach, forget it. You're not going to do it.
Absolutely. And, a lot of EMS agencies have people that they need to put on administrative leave because they have an exposure, or they're, whatever. So right now, MedStar, we're very blessed. We have 500 employees. Only 11 have, through the whole course of the pandemic so far, I'm going to keep knocking on wood, have had to be any type of leave while they're getting tested, that kind of thing, because of an exposure. Only a couple have actually come up positive for coronavirus. But as those people are on admin leave, they're getting paid. So why not, if they're going to be on admin leave for 2 weeks, they have to be quarantined, they're your contact tracers. And you have to pay them. So they're gonna get paid while they're on administrative leave, but they've got a list of 15, 20, 30, 40 people that they need to start doing the contact tracing, and the agency gets reimbursed for that.
Well, I'm saying, you're paying some money out, but you're getting some money in from the other side to backfill it. That's where people have to think about some of this stuff.
Absolutely.
What about, let me shift gears as we kind of conclude here to talk about the relationship between, I'll pick MedStar, I'll pick anybody, an area that's really bothering me and watching all of that's happened with the Floyd case and others, is that we're called to a scene that's under the control of the police, and we see something inappropriate, or we see a cardiac arrest, but we have habitually stood back and said, guys, we're here. Have you instituted any change to make sure that once they call 911 and you come and you see a respiratory arrest, that's your patient?
Yeah, we're very blessed. We have not had, at least to my knowledge, and we would probably know pretty quickly, any significant or really any incident as it relates to that. I think if you think about the concept of crew resource management,
Mm-hmm.
it's one that we've talked about for a long time. And it dates, the normalization of deviance, all those kind of things. But we are in an environment today where this see something, say something really has to occur. So if an EMS provider sees something that probably isn't very good, we tell our people in new employee orientation is that if you're going to say something or you're going to see something or not do something that you don't want people to know about, don't do it. It's just,
Yeah.
have the integrity to say, I think he's under control now. You can release, whatever it is that you have. Now, granted, we've all experienced as field providers patients who are out of control, and we are glad that law enforcement has the capability to control people to protect not only ourselves but to protect the patient from a lot of the things that they could get hurt while they're doing. But we have to have the relationship with the providers in the field, with the law enforcement agencies in the field, to kind of say, I think we're good. We can do some things with some chemical, alleviating factors, if you will. But I think a lot of agencies have learned a lot over the last year about, if nothing else, human physiology, and that there are ways that we've had policies, and a number of agencies have policies where you can't hogtie someone. If they're going to be restrained, they have to have their airway open, they have to be face up, that kind of thing. But engage with your law enforcement community. I just participated in a webinar, AJ, yesterday with the ICMA, International City County Managers Association. And the whole webinar was on EMS law enforcement collaboration. And a lot of it had to do with prevention of a high-risk interaction with someone. So the CIT teams that are happening in where you are in San Diego and Pasadena and all over the country, and certainly here in Fort Worth, engaging in those types of proactive, hey, put a mental health worker, a social worker, a community paramedic, or a regular paramedic with a CIT-trained cop to respond to those behavioral health calls, not really to protect the patient, yes, protect the patient, but also protect the agency, so that you've got trained people going to the behavioral health calls. Eugene, Oregon has a very successful program. I think it's called Cahoots.
Yes. For years,
right.
Maybe decades.
So I think today is the day, if you haven't done it yet and you're listening to this broadcast, call your police department, if you're a police agency, call your EMS agency and say, hey, can we meet to talk about how we better handle high-risk situations, to de-escalate, do those kind of things, and quite frankly, start programs that everybody is sort of talking about now and fund them to prevent a high-risk scenario by having a team that proactively manages behavioral health, the homeless, others that could be a problem down the road. There's a lot of talk about that, and we all need to do a better job with that, AJ.
Well, we wrote about it in GEMS years ago in the wonderful program in San Diego, the RAP program, and then they suspended it for almost 2 years, and then they brought it back. You're never going to get rid of that again. That's sexy new. That's another employment opportunity for ambulance services and a big PR opportunity to be able to have a MedStar or a San Diego or whatever person mixed with a police representative or whoever it has to be, and a social worker. The gang up north in California, they got the paramedics in with a social worker, and then they also got paramedics in with physician's assistants. So one was taking on the nursing homes and the other taking on these other things. But there are some cautionary things here. And one is we're going to be very careful about how we handle domestic violence calls in the future, because the public doesn't realize that that's the number one offensive against police.
Risky call. Yep.
And the second thing is we have to watch what we do about medicating patients, because the lawyers are now looking at that. What you saw happen in Aurora and a bunch of other places, you know, the police saying, can't you give them something? That has to be our suggestion, not their suggestion. So we have to be very careful we don't get sucked into some of these things. But it's pretty clear the world is changing. And by us doing these kind of conversations on a frequent basis, we can spread it out again. I really want to thank you for spending the time today. I want to thank you, NAEMT, for standing side by side with AAA, IFC, everybody, because this is a common issue, man. And boy, if we can crack this nut, we can all win. Fire departments in particular can win, because we could shave off an awful lot of calls and transports if we could have treatment in place. So Matt, thanks again, and let's do this more frequently.
Please, anytime.
Okay.
Happy to be with you.
Okay. Have a good day.
Thanks.